Hello, everyone. We are in week 3, and so I'm going to spend the next few minutes going over this week's module, as well as the course activities and the rubric. You can see this week, your week 3 reading assignments are actually 4 chapters, chapters 19, 20, 21, and 22. And so that is on abdominal exam, male genitalia, female genitalia, as well as anus, rectum, and prostate. And those do all come from your Bates textbook. Important reminders for week 3 include your shadow health modules. So remember, starting in week 3, you do not have multiple turn-ins or multiple attempts at shadow health. So you do need to make sure that you're dedicating the appropriate amount of time to complete this successfully. You'll have an abdominal concept lab, as well as gastrointestinal module and a focused exam on abdominal pain. You do also have 2 Q banks due this week, and those are your men's health and your pregnancy modules. So please make sure on your Q banks, again, if there are less than 40 questions, you are doing all of the questions. If there are more than 40, the minimum to submit in that screenshot is 40 questions. We want you to do your best score. So please make sure you are taking these and reviewing your answers. You can take it in either tutor mode or exam mode when you submit those. You will have a body system video due this week, and so we're going to focus a lot of the attention on how to properly do an abdominal exam and some of the background as well as assessment factors that go into proper examination of the abdomen. And then also this week, you should get your your week 8 group project if you have not already gotten those topics from your instructor. So we're going to talk a little bit about a SOAP note versus a write-up. And so in this week, in week 3, for your abdomen, your documentation is going to be a write-up only. That means that you are going to do nothing other than your objective exam or your physical examination on the patient. In weeks 4 or 5 other weeks, there will be differences in doing write-ups and SOAP notes. And so for this week, week 3 on the abdomen, you are doing a write-up. So you can see comparing and contrasting here of what we're expecting. We're expecting a very detailed physical examination when you're doing a write-up, as that's the only portion of your documentation you're completing. So for an abdominal assessment, we need to first talk about the key organs. And so we have your mesentery, colon, liver, gallbladder, kidneys, spleen, stomach, bladder, appendix, as well as the arteries. And so those are all areas that you're going to be assessing in your video. And then in terms of anatomy, this is just a good review of what the GI tract really entails. So everything from the upper respiratory tract down to the esophagus, you've got your liver, gallbladder, your abdominal aorta, stomach, spleen, duodenum, your pancreas, colon, ileum, small intestines, appendix, and rectum. So abnormalities related to abdominal organs are something we do need to review, and specifically with renal sources and electrolyte abnormalities, we're thinking about potassium and sodium. With adrenal diseases, we're thinking about adrenal insufficiency, hypercortisolism. We have pancreatic sources like diabetes, DKA, HHNS, and so those are just some things to consider in terms of abdominal organs. And when we talk about common or concerning symptoms, patients often present with abdominal pain. They may have indigestion, nausea. If there's vomiting, you need to know if it's with or without blood. Any change in their appetite or early satiety, difficulty swallowing or dysphagia, and then painful swallowing or odonophagia is also something to consider, and then the differences of why those are occurring. Change in bowel functions from constipation to diarrhea, jaundice, urinary symptoms like dysuria, urgency, frequency, nocturia or polyuria, urinary incontinence, hematuria, flank pain, or urocolic. So you'll find in your Bates book some really great items in terms of how to do key assessments with the abdomen, but specifically, we talk about using old carts. So when somebody's coming in with abdominal pain, we want to know that onset, location, character, radiation, palliative, provoking, and associated factors, and then their past medical and surgical history, as well as their social history, and if there's anything there contributory. Something, for instance, like taking NSAIDs often could contribute to gastric ulcers. That could also contribute to their renal function. Whereas someone who uses Tylenol often may have a liver abnormality, or they may have a predisposed liver condition like non-alcoholic fatty liver disease. And so then we want to caution our patients in using certain over-the-counter medications. You'll see a really great figure here from your Bates textbook discussing the upper quadrant and what you'll find there, as well as the periumbilical area and the suprapubic area. So common GI conditions, basically, how are we coming up with a diagnosis? It entails several different factors. So you have your patient's report of their symptoms, and that's going to be your HPI that you're documenting. Again, that's social history if it's pertinent, and the review of systems. Your physical examination is absolutely one of the most important aspects of the entire visit. So you're finding out information while you are doing the assessment as well, but your exam findings are something that should be very objective. They should be able to be reproduced by any practitioner. Then, based on those two factors, your subjective and your objective history, does this patient require further workup for a diagnosis? That may entail diagnostic imaging. And so depending on the body part, the upper quadrant, the lower quadrant, the right, the left, the flank, whatever you're looking at, that may require a specialized test. And so some testing I have listed here, like a CT abdomen and pelvis, that could be with or without contrast. Sometimes it's both. A limited abdominal ultrasound, often done for the right upper quadrant to look at signs and symptoms of possible cholecystitis. An upper endoscopy or an EGD for someone that's experiencing those symptoms of GERD or possibly a gastric ulcer. When we're talking about lab testing, we also want to make sure that we are ordering tests that are necessary for the patient. So routine labs do not necessarily exist in this idea. We want to make sure that if we are seeing the patient for ongoing symptoms or new symptoms, that we are ordering the appropriate test. And so you can see here I have CBC listed, why we would do that, a CMP, amylase, lipase with pancreatic enzymes, inflammatory markers. And then in these common conditions, you can see listed for gastric esophageal reflux, biliary lithiasis, as well as hiatal hernias, paraesophageal hernias, and mixed hernias. So when do we refer the patient? Escalation of care. That oftentimes is when there is treatment failure. So you've done everything from a primary care setting to try and help mitigate these symptoms for the patient. Maybe lifestyle modification, maybe hereditary, but they're just not getting any better with the treatment. And so that is the time that we escalate. As well, if there is a suspected diagnosis outside of our scope that we really need the help of a specialist. If you cannot safely treat the patient in the clinical practice, that's also another really great reason that we want to escalate that care and refer to GI. And then always want to make sure that we're understanding if the patient has an unstable presentation or very concerning, alarming symptoms like hematemesis, painless jaundice, palpable mass, evidence of GI bleed, whether that's rectal or upper GI. So we want to be very sure that we're always aware of those symptoms and we're referring the patient appropriately. So you can just see some visuals here of a gastric ulcer, as well as an endoscopy and what that would look like. And then again, a recap of the GI tract. So with hepatic dysfunction, we want to make sure that we're looking at different signs and symptoms associated with the liver. So in the right upper quadrant, where the liver is located, we also have our gallbladder, our pylorus, the duodenum, the hepatic flexure of the colon, and the head of the pancreas. So just because a patient is experiencing right upper quadrant pain does not always mean it's the liver or the gallbladder. We need to be very aware of the anatomy of what is existing in that quadrant. You'll also see here that box 19.4 has the risk factors for liver disease, and I'll let you look over that. Again, that's directly from your reading, really great resource. Hepatomegaly demonstrated as opposed to a healthy liver, and then what cirrhosis does look like. And then other things to consider when we're talking about the liver are hepatitis and the different forms of hepatitis. So board questions often like to ask you about hepatitis and these hepatitis surface antigens. So this is something that I did want to mention. So when you're studying things about the GI tract, it's not strictly memorizing. You're going to need to be able to apply what these surface antigens mean. So you can see here discussion of IgM and IgG, as well as testing and screening for hepatitis B, and who we should be screening, as well as what labs we should be ordering. In terms of hepatitis C, there is an average incubation period of about 2 weeks up to about 84 days, and testing for acute hepatitis C often involves many issues of blood work and then also testing with imaging. So we'll see that the ALT and AST can be elevated. That is not necessarily a hallmark of hepatitis, but it is something that we do see. The recommended testing sequence does involve the anti-HCV and whether it's reactive or not. And again, there's more information there for you. So we see patients present with abdominal pain often, and being able to differentiate whether this is a very serious condition is very important. And so your physical exam along with a history will help support if this is a can't miss diagnosis like a AAA. So the risk factors for abdominal aortic aneurysm often involve age, a history of smoking, specifically more high risk in males, as well as first degree relatives with AAA. And then you want to make sure that you're assessing appropriately, and some information there, again, all found in your Bates textbook, as well as a visual aid. So on the left side, you can see a normal aorta, whereas an aneurysm featured on the right. Other things to consider, especially with the amount of the intra-abdominal organs that we are dealing with, is potential for colon cancer. And so there are screenings, there are prevention, there are risk factors we need to talk about, as well as morbidity and mortality. But essentially knowing the patient's risk of family history is one of the most pivotal things that we can do. So we have non-modifiable risk factors, meaning those are things that the patient absolutely cannot change: their hereditary background, their age, their gender, those types of things. Whereas we have modifiable risk factors. So a patient who is a smoker, a patient who's very sedentary, who has a diet in often eating red meats or fatty foods, those all contribute to potential for colon cancer risk. And then screening is going to be individualized based on the patient and their own risk. And so that can often involve a fecal occult test where that is sent off. And then diagnostically, if that comes back positive, which there are large numbers of false positives, that is when oftentimes a colonoscopy is performed. And a colonoscopy being more expensive, more invasive, we are trying to do the least expensive and least invasive first. That's something to always remember for boards, is that you want to do your least expensive, least invasive test first, as it's the safest way to treat your patient and the most inexpensive, of course. So again, prevention is going to be based on removing any cancerous polyps, as well as knowing the patient's risk. So when we're talking about renal conditions, there's several different conditions. This is not a culmination or a complete list here, but just some conditions to mention with some good visual aids. So we have nephropathy, we have glomerulonephritis, renovascular hypertension, hydronephrosis. Also on the bottom in the middle of your screen, you'll see the adrenal gland, which does live just above the kidney. And then the different renal pathways in a female versus a male patient. And then another thing to consider when we're talking about renal conditions, as well as we're traveling down the renal tract, is specifically UTI versus pyelonephritis. And when is the condition diagnosed as a UTI versus pyelonephritis? Additionally, there is asymptomatic bacteria, which is when we're finding signs, as in bacteria in a urinalysis without symptoms. And so again, you can see that there is great information here for you on lab parameters, prevalence, current treatment protocols. But specifically, when you're considering is this cystitis, that's usually a lower GU condition, whereas pyelonephritis is an upper and at the kidney level. Pyelonephritis is almost always accompanied by high fever, vomiting, back pain, chills, on top of those already existing urinary symptoms. So great information here for you to review. Also featured in your reading this week, as I discussed, is your chapter 20 and chapter 21, where you're discussing male and female genitalia, as well as sexually transmitted infections, which we'll talk about in the next slide. Uterine cycle is also something to be very familiar with. This is a question that boards likes to ask about in terms of ovulation, luteal phase, and things like that. So I do like to mention this, as well as things in contraceptive methods. You can see on your right upper screen a diagram of the prostate, and then different information in terms of testicular anatomy. Spermatogenesis is featured as well. So when it comes to sexually transmitted infections, there are many great resources out there. I personally choose to use the CDC STD app, which is a great free resource. It was last updated in 2021. And so the information, although very, very tiny on your screen, is from this STD guide by the CDC. And so you can see on the bottom the pocket guide, which is a phenomenal resource. I'm not going to click out of the presentation, but I do highly recommend that you can put in your search engine the STD treatment guidelines and the pocket guide. It gives you a really great printable resource that you can have, or you can go ahead and download that app on your phone. But just to give you an idea of what this information features is the name of the condition, what body part it affects, the treatment measures for it, and then if there is an allergy for the patient, another method to treat. So as I mentioned, with many organs to be concerned about, there's lots of differentials. Again, this is not an all-encompassing list, but this is a good idea of lots of differentials that you may see in the primary care setting, and when to, again, escalate care if that's outside of your scope. If the patient cannot have routine testing done, and it's something that does require stat testing, you always want to do the safest thing for your patient. So now we're at the point where we can talk about your video. And so the highlights of your intra-abdominal exam basically are going to include only the exam, as I've mentioned. So no chief complaint, no HPI, no ROS. You're going to only be doing your exam on the video. You always begin your videos with consent. So you're going to ask your patient to provide consent for you. That only needs to be verbal for these videos until you get to your head to toe. But you are going to upload this as unlisted for your professor to grade. The entire abdominal exam is based on your rubric. So the video should be completed as if everything is normal and this is a healthy patient. Even if that's not the case, please go ahead and instruct your patient prior to filming your video that this is going to be a normal exam for the purposes of this video. Notes and rubrics are not permitted for use during the video. There is no starting, stopping, or editing, which is the same for every video throughout the course. You must be in the camera frame at all times, so please make sure that you have your video or your recording device in an area where we have a wide frame of view. And then finally, watch your own video before submitting. It's very important that you're making sure that all of those items are met before submitting to your instructor. Again, we don't know how many times you've recorded prior to submitting, so we want to see your absolute best attempt. Plan accordingly, as we all know that YouTube takes a long time to get everything uploaded appropriately. So please make sure that you've got several hours built in, if not doing it at least a day before, to make sure that your video gets uploaded in the appropriate time and that you submit by the due date so you do not incur any of the late policy. We absolutely cannot accept any form of video that is MP4 or WMV that is sent to our personal email or the Dropbox. It does have to be the YouTube link. So I've mentioned throughout this presentation that you do need to have a write-up. So again, not a SOAP note, objective only. We do ask that you use headers, which is exactly how your rubric identifies what part of the exam that you're on. And that's going to include inspection, auscultation, percussion, palpation, and then specialty exams. There is no points that will be awarded if you choose to use WNL or you do not write out the findings. We do not use normal limits for documentation purposes throughout the program. You will describe and document a normal exam in detail using medical terminology, and that's usually about 1 to 2 pages in a narrative documentation. All documentation does go through Turnitin, so please make sure that you are using your own words. You're not copying a direct resource, And there's absolutely a zero tolerance policy for using any previous student work. So those things do show on a similarity report as well as any AI generated exam. So please make sure the best way to make sure that you have zero similarity to another student's paper is not to use it. Go ahead and use your rubric, identify each item and document it as such based on your Bates reading and based on other resources that are evidence-based. So now we are on to the key components of your exam. So very first, the number one thing that you're going to do before you start physically examining the patient is always inspecting. You're going to be looking, then listening, and then you're going to tap or percuss and then palpate. So that is the specific order that we do use when it comes to the abdomen. Looking involves skin appearance, contour, movements, masses. You're going to be looking at the umbilicus. So you'd be raising the patient's shirt to about their breastbone. Again, you're going to keep them covered throughout. You're going to listen before touching. So the presence of bowel sounds, their frequency, their characteristics. And then with percussion, we're checking for tympany versus dullness. What does that mean? Where does it change? So bone will sound different than organs. And then additionally with percussion, we're going to be percussing over all four quadrants, as well as the liver, the spleen, the bladder, and the costovertebral angle, so the flank area. And palpation with light palpation first, then deeper palpation. So abdominal auscultation, again, why are we doing this first? That's really so that we do not alter any of the characteristics of bowel sounds by distending or moving those organs around when we're pushing. So listening for sounds, a normal bowel sound is 5 to 34 per minute. If inspection revealed any pulsatile abdominal mass, that's very concerning again for a AAA. So you're going to auscultate over various areas, but you may identify a buoy or a turbulent flow. Friction rubs are abnormal, and so those may occur over abdominal masses, the liver, or the spleen, and then conditions where those are present are in possible hepatomas, gonococcal infection of the liver, splenic infarct, and pancreatic masses. So what you can see on the left side of your screen is your Bates figure, which shows the abdominal aorta, as well as your renal arteries, your iliac arteries, and your femoral arteries. So for modesty of your patient, we are not asking that you expose the femoral region. You would place your stethoscope over their clothing in that area, and then you would verbalize that the best way to auscultate in the femoral region over the femoral pulses would be specifically skin-to-skin contact with your bell and your diaphragm on the actual skin of the patient. So we must be able to see this landmark, as well as your stethoscope placed in the correct location while you're verbalizing the name of where you are auscultating in order for you to receive full credit. Do make sure that you are performing that bilaterally. In terms of abdominal percussion, we want to see you percuss in all four quadrants, and you're going to note the difference again in tympany versus dullness. So when you're percussing, we need to hear what you are hearing and where you heard that. You should be percussing many areas, not just over one spot in each quadrant. And dull areas can characterize an intrauterine pregnancy, an ovarian tumor, a distended bladder, large volume ascites, large liver or spleen, whereas dullness in the flank should raise concern of ascites. With the bladder, you're going to verbalize when you should hear tympany versus dullness. The bladder is ideally empty before percussing. Causes of distension of the bladder are mentioned there for you. And then with kidneys, which is what this figure shows for you, is testing of the costovertebral angle. So pain with pressure of fist percussion supports pyelonephritis or associated fever and dysuria with that. However, you do want to be sure that it is not a musculoskeletal etiology of your patient's pain. Again, with abdominal percussion, you're going to want to test the liver. So in figure 1918 in your book, you're going to find the bottom edge of the liver. So dullness may be impacted by enlargement, or if there's free air in the abdomen, or even if it's displaced downward with chronic COPD. Measuring the liver span is also part of your rubric. So please make sure that you are identifying that, reviewing your Bates book. And then splenic dullness, so verbalizing it, normal is no dullness. That is Castell sign and a moderately accurate test. So again, all of this is featured in your Bates book. This is just a review of your rubric and what we're expecting. For abdominal palpation, you're going to start with light palpation. So using one hand with a very gentle kind of gliding motion. I do recommend that you gently glide your hand over as opposed to just press in 4 different spots with light palpation. By doing so, if you start in the right upper quadrant and guide your hand over to the left upper quadrant and come back through the middle of the abdomen and the lower abdomen, you're making sure not to miss any areas. You're going to then repeat that with a deep palpation or a two-handed method. And at that time, you're going to verbalize to us, I'm watching for any guarding, rebound tenderness, or rigidity while I'm palpating the patient's abdomen. You can again ask your patient if they're experiencing any pain or discomfort while you're doing this. Then you're going to palpate the liver on inspiration. So an enlarged liver would be concerning, again, for conditions like chronic liver disease or cirrhosis, and then palpating for the spleen on inspiration. So it does help to appreciate splenomegaly accurately. And so you should not feel the spleen in a normal exam. Special techniques and tests. So this is the end of your rubric. And so ascites testing by fluid wave or shifting dullness are demonstrated here. You can verbalize this in lieu of performing, but this does give you a bit of a visual aid to understand what these tests entail. With testing for possible cholecystitis, this is when we're looking for Murphy's sign. So in order to correctly perform this, you're having the patient take a deep breath fully and relax basically with all of the breath kind of loosely let out. And then upon them taking their next deep breath in, you're going to be placing your hand, as you can see in this figure, in the right upper quadrant. And if the patient is reluctant to take a breath or sharply winces, anything like that, that is considered a positive Murphy sign. And that is absolutely an indication for you to get further testing at that point. It does not necessarily mean 100% certainty that the patient has cholecystitis, but it is a concerning abdominal exam finding, which requires further workup. And then our special test for appendicitis. So there are several. We have our psoas sign, our Rousing obturator, as well as McBurney point. There are other abdominal testing for ventral hernias and abdominal wall masses in your textbook. So there are great reviews there for you. You do need to make sure with performing whichever of the tests that you choose for your appendicitis sign that you are demonstrating it appropriately as well as verbalizing it. So that's all I have for your week 3 and your abdomen. I hope that you found this review a very easy way to understand a lot of the intra-abdominal features that we may see in our assessment. Please make sure that you complete your sync session summary and that you submit that to your Dropbox before the due date next Monday. If you have any questions, please reach out to your instructors, and I wish you all the best this week.